I guess we can begin, I suppose. Yeah, thank you guys all for coming on. I know it's a little bit later in the day, but hopefully it's a nice way to wind down and talk with Prem about your different perspectives on this topic.
Looking forward to the conversation.
Yeah, absolutely, absolutely. All right, I will. I'll get us kicked off, and then you can introduce the rest of the guys. I see everybody's kind of sort of filtering in after coming off the last panel. So good evening, everybody. We're into the final stretch of the first day of the summit. So thank you all for participating. We've had some really wonderful panels today, and we're kind of topping it off with three folks who are no strangers to HITLAB events, coming back for more. We have Nassar, April, and Fran, who have had some really wonderful conversations with us in the past, and Prem Sreenivasan, our very own Director of Medical Affairs at HITLAB, is going to lead this discussion with these wonderful folks around real-world evidence and data analytics. So take it away, Prem.
Well, terrific. Thank you so much, Jerry. Appreciate it. And good evening to everyone. And welcome to this very interesting session on real-world evidence, data analytics in local government, global health systems. So there is a lot to unwrap here. And I'd like to welcome the session participants. I'd like to start with April, Fran, and Nassar for taking the time from their busy schedules to be at the session to offer us their insights and thoughts to unpack this very important and complex area. So as we get started, maybe I could go around the virtual conference hall and ask each of you to introduce yourself, perhaps start with Fran, if that's okay, and then with April, and finally with Nassar. So go ahead, please, Fran. Welcome to the session.
Thank you so much for having me. It's always exciting to be able to participate in the HITLAB programs. I'm Fran Ayalasomayajula. I am the president of REACH, a global social impact organization. I have over 25 years in the industry, formerly the global head of digital technologies and strategy at HP, and currently the CEO rather of RTI Innovations. So very honored to be here today.
Well, welcome. We look forward to your thoughts. And April, perhaps you could take a minute to tell us a little bit about your efforts and your background, please. Thank you.
Absolutely. Sure. Thanks, Prem, and thank you to HITLAB also for having me. I am April Smith-Hirak. I'm the Regional Health Administrator out of the Office of the Assistant Secretary for Health at the Federal Department of Health and Human Services. So my role is a bit of a connective tissue role, bringing parts of our department together for our regional office. I'm happy to be here today. Thank you.
Thank you, April. And Nassar, good evening to you and welcome to the session. We look forward to your participation, and perhaps you could take a minute or two to tell us a little bit about your experience and background, please.
Absolutely. Thank you, Prem, for having me. It's always a pleasure to be on one of HITLAB events. So I am the Chief Information and Digital Office for Jefferson Health, which is an 18-hospital health system serving Greater Philadelphia area. We are a teaching hospital, and we also are a payer. My background is all in IT. Prior to joining Jefferson 4 years ago, I was at New York Presbyterian in New York. And prior to New York Presbyterian, I was with Yale New and Health in Connecticut. Thank you.
So welcome to each of you. And as we get started, I want to go around the virtual conference and, perhaps identify some key areas that we hope to cover in this session. There is a lot of material here. And I'd like to start off with, what is RWE and what is the promise that it seeks to offer in terms of improving healthcare, not just locally, but on a global basis. And I'd like to, again, walk through the same, starting with Fran, perhaps to start this off, and April providing a more US governmental-based perspective, and Nassar with an IT focus. So I'd like to start off with Fran, making some remarks on that front.
Sure, absolutely. Well, as we've had the good fortune of sort of discussing as a shared group prior to the session today, this idea of RDW it's a very large one, right? I think it's a sort of a catch-all phrase for all things around data in a variety of settings, and how those then can turn around and be applied in ways that can directly impact, and hopefully in positive ways, the outcomes for care. And that also shows up in the ways that we deliver programs and we elect to fund programs. And these data sources and data sets can come from a large variety of both public as well as private sector environments. I myself am often, when I think about it, drawn to recollect my time with the Department of Commerce when I was running data collection for a 3-state region in which we were collecting NAMSI and HAMSI data, data from the National Ambulatory Medical Care Survey and the hospital care surveys and the national HIS surveys. Those are some of the bread and butters, which I'm excited to hear April talk to us about. But today we've moved on to also incorporate data coming from patient-generated sources, such as wearable devices, to information coming directly from clinical settings, and being talking about the convergence of all these data sets from a variety of spaces coming together. And the reality is that there's lots of data that we're sitting on top of that we're currently not even beginning to tap into, that can tell a real compelling story about who people are and how they live. And we often refer to this as our digital twin. So I'm excited about this conversation that we're having today, and can't wait to hear from the rest of my colleagues discuss their definition on RDW. Yeah.
April, I do believe you have a very novel perspective on this, and coming in with all the various tools and services that your organization is providing. The audience would be very delighted to learn from that. So I'll leave it with you to take us through your journey in this space.
So the federal government has massive amounts of data, and the beauty of federal data sets is that they're public. So by and large, they're accessible to anyone who wants to do research or who wants to delve into that data. And sometimes it's a matter of understanding where those data sets come from and what they mean as well. So, the NHIS that Fran mentioned is a fantastic and really one of our benchmark data sets that assesses, the health of our population. We have data sets that come not just from the federal level, but from our state and local levels as well. Many of our states have public data sets. The sheer amount of health data that is out there is startling and overwhelming often if you're not well versed in data. And even if you are, if you really understand how much data there could be to analyze, you could do it for the rest of your life. And I think the challenge is, as Fran mentioned, as we begin to move from data sets that are traditional federal data sets that we collect and maybe collect, once or twice a decade, every year, every other year, and then we release, and by the time we've released them, and as the federal government, we want to make sure that the data that we're releasing is reliable and that it is a clean data set and that it is exactly what it was intended and what it purports itself to be. And so because of that, it takes us a very long time sometimes to release data sets. So we're not working in some of the real-time modalities and some of the newer data that's coming out that is not federal government is. There are some areas of federal government where we do have more real-time data, but by and large, when you're looking at these larger data sets, the nature of the beast is that they get released a little bit later. And so being able to contextualize that with the larger data sets that are more population health based, that give us kind of like our disease prevalence and all sorts of other important information, and then marrying that with the real world data that we have coming together, sometimes it's a little bit difficult because of that time lag and the time difference. It's almost like you're comparing two different universes. And then to be able to analyze and to look and see what is relevant, what's not relevant, what's an artifact of when the data was collected versus now, and what is changing. It's a challenge for researchers, but there's definitely a wealth of data to be mined within the federal government, and also a lot of complementary data sources that come not from federal or state or local resources, that come from the private industry and other partners from NGOs from across the globe. So it's an exciting time to be in data.
That's wonderful. That's terrific. Perhaps we could place in the chat some of these resources that you identified, and it would be most useful for the attendees who are in the healthcare and research areas. So Nassar, I know you have a very unique perspective on this coming in and I'd like to request you to take us through your views on this front, please.
Like I'll provide you a point of view from healthcare providers, right?
Yes.
Hospitals, health systems. Historically, health systems, hospitals have relied on data within electronic medical record system or electronic health record systems, right? This is the data that typically physicians or providers collect when interacting with nurses, and very heavily clinical data. And even the data that are not necessarily in EMR, such as billing data or claims data, are derivatives of EMR data from other systems. So simply we leverage them because that we don't have direct access to that data. Our hospital may not have direct access to other system EMR data. So they look at claims data, billing data, or registry data, et cetera, right? And that to date, even today, that is the main source of data that providers, physicians, nurses, other providers use to provide direct care to patients. Now, what has emerged in recent years is a pretty robust set of data that is outside EMR. So for instance, patient-generated data, RPM, is one subset of that. So all the wearables, Apple Watch and Fitbits and scales, et cetera, are generating tons of data. There is mobile devices. There's a whole section of social determinants of health related data that now is being incorporated. It's still very, very, I think, early stages, at least from a hospital point of view and provider point of view. And in general too, I would say very early stages, the CH data is not necessarily integrated very well in the patient's care plan. But the amount and velocity of data generated outside EHR is huge. And in next few years, the data generated outside again EHR is going to dwarf what's in EHR, and it's going to increasingly become a lot more important, a lot more real time, especially the patient generated data around their health, their mental health, their physical health. Is going to be much more real time and much more important and much more significant in terms of volume, and increasingly more important for health systems like Jefferson to incorporate into the care plan. So let me stop there. Otherwise, I'm fascinated by what April and Fran covered.
So, Fran, I think you were, just called into action there. So I'd like you to respond to that and perhaps, add your views to what we just heard.
Yeah, so I think that everything that has been said is spot on. I think that we are plagued, unfortunately, with quite a few challenges, right? Even today, I noticed, Nassar, there was a remark you made. You mentioned patient-generated data, and in the same breath, the term, RPM, which is remote patient monitoring. Well, with remote patient monitoring, that's sort of, generally speaking, is initiated by the clinicians. So we don't consider that to be patient-generated data. But when a patient elects to generate that data on their own, right, gets their Fitbit, and wants to take those numbers into their clinician's office, they aren't embraced. The data is not accepted most of the time, right? The majority of the time. I'm sure there's some folks out here who say, oh, my clinician is great, but that's probably one in thousands, right? Who are actually taking that data on board. And we still struggle with clinicians in general with their adoption of digital health technologies and digital tools. So, it bears the question, at what point do we actually get to a level of confidence with this data to start, leveraging it in ways that can be beneficial and actually show up, in valuable ways for the clinician and for that patient-clinician interaction? Because today it's not. I think there's quite a few reasons for why that is the case, but I would love for either you or April to chime in, just jump in right on top of my comments here, because I think that's where the rubber hits the road, right? Like how it really shows up in these encounters between providers and patients.
So that's a great point, actually, and something that we discuss a lot at Jefferson. So let me just present a point of view. First of all, you're absolutely right that we only accept data in EMR once a physician orders it, right? And there is a ton of data that patients are just collecting on their own. Now, there are some issues with the data. Number one, probably the biggest one, that context is missing from the data. For instance, you think about heart rate monitor. What does it mean if 2 o'clock at night in the morning, my heart rate jumps, right? I could be exercising at 2 in the morning. Who knows what I'm doing, right? And so on and so forth. There are a lot of examples that, and I talk to my physician colleagues that would give me that basically, look, I mean, and I think it's a valid point that context is missing. And so we do need to contextualize the data, right? That's absolutely true. And I think some of the technologies that I'm excited about is, again, I think tongue-in-cheek AI, so some of it is pattern recognition and looking at the data, over a long period of time, recognizing patterns and eliminating any one-offs, because there are just, if I look at my own patterns, there are things that I don't understand, right? And I'm sure that there is good reason for it. And if you think, and just yesterday we were having discussion that a typical physician patient meeting, if we are lucky, is 15 minutes. Otherwise, average is, Fran, you had shared somewhere like 8 or 9 minutes.
Yeah.
Per encounter, and that's just not enough time for a provider to look at weighing machine data or Fitbit data or pulse oximeter and so on and so forth, right? So one of the challenges for us is that as data is being created and it's valuable data, it's just amazing. How do we synthesize it and present it in a format that is truly actionable, without a physician needing to go through like a month worth of, say, heart rate monitor data or some other piece of data, right? So we have to contextualize it. We have to make it useful. And I think there are ways to make it, but I also believe that we are in really, really early stages of all that.
Mm-hmm.
I think the exciting thing about these modalities and these new ways of producing data is that it takes a little bit of the onus and places it on the patient themselves, the people who are engaging in care. And it allows a conversation where the caregiver, the provider is having the same conversation, but in a very different and new way that engages more with the patient and with the patient's data, more than just a single data point of a patient in the office. So, as a federal government, how do we work to enable a useful modality for that? And, I think we're still figuring that out. We're a little bit later on the bandwagon. We are purposely a little bit slower to move. We don't like to follow trends as the federal government because no one wants their government to be following, the latest TikTok trend. And then it turns out that was just a fad. So we're purposely cautious and purposely bureaucratic, and it's to protect, the way and the integrity that medicine is practiced. And so it's difficult because we have only just now even begun embracing truly telehealth and as we talk about, telehealth and the delivery of medicine from anywhere but a brick and mortar location, then we have to start thinking about how do we have all of these other data sources that can support that telehealth. And I think this is where the conversation is becoming a little bit more dynamic, and the federal government is really trying to examine these and identify what is it that we need to do that can create a landscape that allows for this data to be generated and to be interpreted in a meaningful way, and in a way that doesn't potentially harm patients.
Prem, do you mind if I jump in? I want to ask a quick.
No, please do.
Here, I'm to April about that. April, I was curious, do you anticipate then that there's going to be a new series or perhaps special surveys or special studies that are going to start to come to be funded through HHS that's going to examine this data in a different way, or even begin to collect data in a different fashion in the future?
Well, I think what you see right now is we have a number of innovation seats, even within the Health and Human Services Department. So my office has an innovation office. We have BARDA, we have, an innovation center at CMS. We have innovation centers all over. CMS has been funding demonstration projects for years with new technology and new modalities. And I do think that we're getting there. We're historically, 10 years behind sometimes. And I know that that's very frustrating. But I think that we are focused on innovation and particularly on innovation ways that can provide more equity in the health and healthcare system. And I think that in order for us to do that, we are having to look at different ways. How are we collecting data? Are there better ways that we can do this? What is it that we're doing that puts risks to patients? Are there regulations and other rules and guidance that we've issued that are counterproductive to where we're going as a medical field? And those are very difficult questions that are far above my pay grade. But yes, we have innovation sources and seats that are looking at all of these questions and are constantly trying to move the needle forward and to allow a landscape that can support that growth in the field without endangering the safety and privacy of patients. So I think it's a delicate balance, but there's definitely a number of places within the federal government and within Health and Human Services that are working to do just that.
Yeah, I know from REACH's perspective, we've sort of seen that show up in some of the newer grants that are made available, right? Research grants that are out there, that they're really looking for ingenuity in terms of the way that we're collecting data. Decentralized data is, a great aspect of that, how we're leveraging technology to make that happen. So I'm really glad that that you have a positive outlook on where that's going to go in the future.
Yeah, and I think challenge.gov has also been a wonderful resource for that to really, highlight the places in the federal government and within HHS that are really looking for innovative practices. And many of those might be data collection practices.
So just a very quick follow-up, April. So when do you, what are some of your estimates in terms of when some of these would be made available? What's your prediction, so to speak, if you can look into your crystal ball?
My crystal ball is so foggy. I think that the best answer I can give you is probably not as quickly as some innovators would like, and probably a little faster than many people who are cautious and ethicists and would also appreciate. I think that there is a happy medium there. I don't think that it's going to happen tomorrow, and it's not going to happen all at once. We'll begin seeing innovations and changes in practices in data collection. And sometimes it might be something as simple as like enabling collection on a tablet versus paper. We saw that with the Scantrons back, way back when if you're doing a paper-based survey, to be able to do a Scantron and put it through a machine instead of having to like hand code and enter data into a giant mainframe. We've seen those innovations happen, and they happen, kind of in drips and drabs sometimes, but it is definitely moving forward. And I think that actually the environment with COVID and the nature of the pandemic has maybe pushed some of that a bit more of a rapid course than it had been before.
So Nassar, from your vantage point, from the health systems standpoint, what are some of the items that you feel are most appropriate in the prior remarks by April and Fran? How do you feel that the health systems could benefit from some of those developments and suggestions?
That's great. So look, I mean, we are already benefiting from the data that April mentioned. So we do use data sets. So certainly, claims data set from Medicare, Medicaid, billing data sets, and I think where we are focusing now is social determinants of health. That's big, and I think patient-reported data, patient-reported outcomes, both self-reported via mobile app, for instance, or I think the real focus in since COVID, I would say probably quadruple is in RPM. Prior to COVID, we had RPM initiatives, but they were small. We had telehealth initiatives, but they were like less than 1%. And one of the, I think, positive things during COVID, if there is anything positive, is the exponential rise in adoption of digital technologies. That has opened really many, I think, new doors for us in terms of collection of data, right? So RPM is certainly one of them. Patient-reported outcomes is another one. And just generally, collecting of social determinants of health data, both at the meta level and at the individual level. For us, individual level data has been more challenging. So the more like zip code level data, or city level data, that's easy to come. And again, I kudos to some of the government data that is available out there on, we can predict, for example, life expectancy based on a zip code, for instance, right? Which is great. Or OPI use is another great example that our team is working on, predictions. And this is all great, but they are not yet translating into individual level, right? So we don't have that granularity right now. And our solution to that has been, how do we collect and how do we prompt the patients themselves to provide us data, for instance, on homelessness, right? Or food or transportation, et cetera, right? So this is where I see a gap and a delicate balance on how do we collect this data, whether each health system collects their own set of data directly from asking from patients. We know that there are sources out there, right, that have this data, right? And how do we acquire those data sets and marry it within our electronic health system? And there are all sorts of issues. There are some technical issues, there are some ethical issues in doing so, right? I mean, it's not, I wish it was a straightforward answer that I can tell you, but in terms of priority, these are the priorities that I mentioned. Or for us, non-EHR data. So we have data in EHR, and the SDH data, RPM data, self-reported data are some of the areas that we're looking to marry with EHR to really provide a much better, I think, picture to the providers.
So Fran, from your vantage point, how do you see these initiatives coming forward, particularly as related to your programs, many of which are, also aimed at different parts of the globe? How do you see this coming together from your standpoint?
This is gonna sound so horrible because I'm gonna say not well. And I don't mean to be the pessimist. I'm actually naturally a conservative optimist, but that conservatism comes in the reality that I think, having looked at the data for so many years, right, starting my career in epi and public health, and appreciating and having participated in the collection of these major data sets that April is focused in on, and working very closely with provider institutions on the delivery of care, and seeing how slow the progress has been, and how sometimes it seems as though we feel as though it's sufficient to just say that we can identify where problems are, but not actually translated that into creating for solutions is a big problem. Let me give you an example of this. We ran a study at REACH, which actually just had concluded earlier this year. So it was ran during COVID. We have over 900 women respondents. They were all pregnant and new mothers who participated in the study. And we unfortunately had over 15% who had stated that they felt that their clinicians did not have enough information about them. They felt that their clinicians didn't have enough information to make good decisions about their care. That there were 10% who felt that they really wish that they could have another provider. They would choose a different provider if they could. And that they felt that their clinicians didn't care about them nor cared about their baby, their unborn child. And of course, that leads us now to, you do a study just to do more studies, right? So that leads us now to asking the question, to beg the question, why is this the case? Why do they believe that? And we also, some of the things that we found were that, the digital tools during the COVID were available, but they weren't being utilized. We had less than 10% who actually had utilized digital technology in any form, and none of it related to their pregnancy whatsoever, which during the pandemic is a really super unfortunate that we would still have women being exposed who could have been, for many of the things that they were needing, been seen or treated virtually. So those are problems, right? I think the other problem is that when we start talking about social determinants of health and using things like zip codes as a pinpoint for determining the outcomes for a patient, is it nature or is it nurture? And I'm more of the nurture type. And we see this when we look at amazing programs like in Queens, New York, where self-help community services works with older adult populations. They're actually throughout all of New York. They have programs in Boston, Chicago, and San Diego. And the zip code in particular in Queens, New York, where if you just went based on their zip code, you would assume that everyone is impoverished and that everyone's dying. But in fact, the communities that are there where the self-help community program is delivering their services, they have their hospital rates of emergency are well below the average. Their rates of clinical depression are way below the average. Their life expectancy is certainly much more than those of what would be described as being the the prognosis for someone living in an undesirable zip code. So I think we need to kind of think about how we're using the data, the questions that we're asking, and what it is that we're intending to really do with that data. And if it's just to spend more time talking about what we already know, which is that people with socioeconomic challenges are more likely at risk to have certain challenges, then I don't think that we're doing much to address issues. And we've got to get savvier and start to use this data to create for more dynamic programs. Many of the initiatives, in my opinion, and I'm curious, April, what your thoughts are on this, but I find that the census are so important, and the data that's coming off of and deriving from these surveys, these studies, have the opportunity for us not just to seek more funding, but to seek new, creative, and dynamic ways to respond to the needs of communities. And that is the thing that today continues to be missed.
Yeah, I think what we see a lot is there's been a trend with new data sources and new ways of working for particularly cities to hire chief data storytellers, right? And that's exactly the role of that data scientist, is to tell the story and provide the context of what that data is saying for that particular jurisdiction. And I think, in my office, we've really looked at some of the different tools that we have in our toolbox and what we can do with these data sets, because the data sets are only as good, like you said, as how you use them and how you can contextualize them. For us, it's really important that we help our jurisdictions to understand the context of that data and how to approach what you're learning from it. So one of the ways that we've been trying to do this is using the census data, using the data tracks. And I put up a link for the Minority Health Social Vulnerability Index. We have a number of different indices that are GIS based. And so what we're finding is, well, it's really hard to compare a large data set to a large data set because it literally is comparing apples and oranges sometimes. It's much easier to layer data on top of data without having to make that one-for-one comparison. So what we're able to do is we're able to look at a map in one of our jurisdictions and see where we have a high social vulnerability index and where within that we have resources. And then we can often overlay on top of that data sets that talk about disease prevalence. And so that's when you start to get a really rich picture of what that real world data really is telling you. And when we can do that, then we can begin to appropriately provide resources to different communities. So then we know this community has high rates of cardiovascular disease and asthma, and they have, based on the EPA data that we have, they have high rates of groundwater contamination, or there's an other environmental irritant that might might be part of the asthma situation. But also, it's going to be really pointless if you send your patients to the doctor and the doctor says, go outside and take a walk, because that's not safe. So it helps us to problem solve and to really look at that real world context for all of those different data points. And having that sometimes on a map is just a little bit easier for us to understand and to contextualize what that data is telling us. So that's been one of the approaches that we've taken. And so far, it's been very successful. We're working on doing a little bit more with that. And I think also there's an opportunity there for government to lay that foundation of these GIS layered maps and have all of that data, but then to have individuals and companies come in and work in that innovative space with data to say, well, can we apply any predictive analytics to this? Or can we talk about what would happen if we put a grocery store in this food desert? How would we expect that to impact all of these different factors? And you can do that based on other research. You could extrapolate. So I think that the possibilities are really exponential there. And I think that we're beginning to lay the foundation of a different way of looking at data as government.
So Nassar, from your vantage point, do you see that this could open some brand new doors from the health systems based on the richness of what April just described?
Absolutely, we're already leveraging some of it, as I mentioned. But this is, I think, the new frontier. This is the future. I think way beyond EHR data, right? Or integrating data with EHR, I should say. Where I think if I take a glass half full stance and say that, look, 10 years ago, if I compare ourselves, we are in a much better spot. 10 years ago, I didn't even know what SDOH is or what RPM is. And nobody was talking about these things, right? We're talking about all the right things. And we are now, the challenge of today is different. And it's a good one, I think, compared to, again, 5 or 10 years ago, which is how do we leverage data? And how do we provide an equitable healthcare to the populations that we serve? And in some senses, the data around population and layering of data that April mentioned, I think, is the right way for us to think about. And that's the reason that providers are now looking at data outside EHR data, because even today and up until very recently, EHR was the source of truth. If you're a patient and you're seeing your provider, it doesn't matter who the provider is, they're going to look in their system, you're looking to look at what data I have. And if a patient tells them something new, they'll just enter the data into EHR. So look, it's still EHR, it's important, it's still there, there's no question about it. But in addition to EHR, there is a realization that these other sources of data, whether it's social media usage for mental health, whether it's environmental data, and many other sources, is very important, depending again on the nature of the disease, nature of the patient, how we treat them. And I think another big change, and it's, I think, the movement from fee-based service to value-based service have been very slow. I mean, again, 5 years ago, we thought that we'll arrive there in 2020. We have not arrived there yet, but we are moving in that direction. And if you think about value-based care, looking at a patient as a person, right, is I think the center of everything. You're managing a person, not necessarily a patient. That's where I think these other sources of data become a lot more important. When you're thinking about, hey, how do I provide care to a person who's not necessarily thinking about their healthcare? Because look, I don't think, when I wake up in the morning, I don't think, hey, what's going on with me? Nobody thinks about their healthcare. Nobody wants to think about their healthcare in the morning unless you're really, really sick, right? And the idea of population care is, how do you provide care to a person even when they're not thinking about whatever their condition is, or even if they have a condition, to just think about them as a holistic person. And that's where rest of the data becomes very, very important. And all healthcare systems are focused on it. It is early days. These are early days of using non-EHR data, I must say that, but certainly an area which has tons of potential, and folks are exploring it. And I'll just give one data point, and the reason that I think glass half full is every day I think there is at least, I don't know, a dozen startups. There are so many startups I have lost count. I used to track them a couple of years ago. I cannot track them, which is, I think, a good thing. And in each, just in behavioral health, if I look at, there are probably over 100 startups just in that one area, women's health, and you can go, different areas. And this is, I think, this tells me that there is a lot of research being done. There is a lot of dollars being spent, and this is important for healthcare organization, but we are still in the early stages.
So Prem, do you mind? I would love to
comment.
No,
please do.
Yeah. So Nassar, I have to applaud you for what I think is perhaps the progressive approach that Jefferson is taking, right, and is taking under your leadership, because our data is not showing that amongst other clinical institutions, right? So REACH, we've done global studies, and we've done some US-based studies, all of which have shown, and amongst international key opinion leaders within this space, all being practicing clinicians, that beyond the clinical care, the medical care, they feel as though their hands are somewhat tied in their ability to influence those other determinants, those other factors that are influencing outcomes. And that there's any shimmer of hope or light in their ability to do that, it comes down to the systems, the institutions themselves taking a stance and creating for provisions that enable them to be able to provide those degrees of care to patients, because today they're not able to. And it's not to say they don't recognize the value, they all of which recognize the value, but I think there's like two inherent flaws. Number one is in their definition. So when we talk about things like health equity, you know, clinicians often struggle in a proper definition of health equity. There's some misgiving that by giving everybody access to the same things, that somehow everyone will have the same outcomes. And that's not health equity. So that's number one. And that's an indicator that we create protocols and standards of care that don't accommodate for variations in what shows up within our clinical settings. So I think you're spot on. I love the direction that you're going. I like to see that being able to influence your peers, because I don't think that it's there. And you're right, there's lots of startups out there. There are over 1 million healthcare apps that are published, over 1 million. So you're right, there's a lot of technology that's also there, but the systems that we have today and our continuous perpetuation of a fee-based system inhibits us from being able to really introduce value-based medicine and introduce digital technologies, which is why we are still in the fight to make sure that telehealth and remote patient monitoring is something that's well considered, and not just sort of staying where it is today, but growing into 2022 and beyond. Because right now it's not really clear what that's really going to look like. It's a real struggle.
So I want to, take the time to thank each of you for this very insightful and thoughtful discussion on where this area of RWE is going to go forward. I do truly believe that I should have invited you for a full day session. And I think I have more questions, and there are more questions in the chat, but I want to take a moment to go around the virtual conference hall today to thank each of you for taking time from your busy schedules, to offer us your thoughtful remarks, and congratulations on moving this field forward. And we look forward to your guidance and to your initiatives in taking healthcare to a brand new level. So congratulations.
Thank you, Prem.
Thank you.
And thank you,
so
Fran and
much.
April.
Thank you, Fran. Thank you, April. Nassar,
Wonderful, guys. Really, really wonderful conversation there. Really great to hear from all you different leaders from all of these different parts of the health system and stuff. And we'd really love to hear more of the conversation, but unfortunately, we do need to wrap up. But like I said before, at the summit, the conversation can continue in the networking room. So please do feel free to hit up Nassar, April, and Fran in one of the networking rooms hereafter, and continue this really important dialogue and stuff. But really, thank you, April, Nassar, and Fran for coming on, and Prem for moderating.
Thank you. All right.
Thank
Have a
you.
great day.
Thanks, everybody.